Now, new national guidelines for sexual assault treatment units are due to be published tomorrow at a conference in Mullingar. I'm joined in studio now by Dr. Susan Miner from the Rape Crisis Network of Ireland and by Aisling Walsh, a clinical nurse specialist at the Rotunda Hospital. We're going to talk a little about the guidelines and about the impact of sexual assaults on survivors. But first, our reporter Aisling Riordan met the team at the sexual assault treatment unit at the Rotunda.
Now I'm here in the waiting area of the Sexual Assault Treatment Unit at the Rotunda Hospital, and I'm meeting Dr. Maeve Ogan, who is Medical Director of the unit. Maeve, tell me a bit about what happens here.
Okay, well, this is one of 6 sexual assault treatment units around the country, and patients come here. The majority of them are brought by An Garda Síochána after they have reported an incident of sexual violence. Here at the Rotunda, we are open 24 hours a day, 7 days a week for patients who wish to come or have to be brought to the sexual assault treatment unit. And when they arrive here, they meet with a support worker from the Rape Crisis Centre, and they then meet our assisting nurse and the forensic examiner, who will be an appropriately trained doctor or nurse sensitive to the patient's needs and the requirements at this time of immense personal crisis.
This is the unit itself?
This is the unit. It's small but functional to provide the care that we need. The most important thing is not so much the environment, but more that the care we provide is responsive to the patient's needs. When the patient comes in, and of course they can bring somebody with them, a family member or a friend, somebody as a support for them, they come into this area here, and we explain exactly what's going to happen when they come here. So we take their informed consent and explain everything in detail, and then we take some details of the incident that occurred. That helps us guide the particular samples and examination that we need to carry out, and it also helps us guide the care that the patient needs afterwards. The other thing to remember is that lots of patients who come to us, indeed the majority, will not have any injuries. People sometimes think, oh well, if I'm not injured, if I'm not sore, maybe it wasn't sexual violence. That's not true. Sexual violence can happen in the absence of injury, and indeed there can still be quite a bit of forensic evidence that can be collected even in the absence of injury.
On average, how many patients would you see?
We see a little bit less than 1 person a day, and between 300 and 400 patients every year here at the Rotunda. Nationally, in the Sexual Assault Treatment Unit services, we see about 700 patients every year. We see men and women here. This is not just a service for women, even though it's here in a maternity hospital. This service is for men and women over the age of 14 years.
In most cases, do people know the person who sexually assaulted them?
I suppose it is a mix. There are a number of patients who come to us following an episode of intimate partner violence, so it will be an intimate partner who they obviously know very well. Many other patients know the person possibly as an acquaintance or a friend, and then others again will be what people would think of as stereotypical event of sexual violence, where it's somebody they have never ever met before. And of course some of our patients will feel in some way culpable, not that they are at all culpable, but they may have had a significant amount of alcohol. There may be some memory loss associated with it, and consequently it's very important that we reassure our patients that they are not responsible for what happened to them, and support them in that.
Now this is the examination room, and I'm with Aisling Walsh, who's clinical nurse specialist here. Aisling, tell me what happens.
So when the patient comes into the examination room for collection of forensic evidence, firstly they're asked to put on a disposable gown, so they can remove their clothing in the bathroom beside us, and then they come back into this room for collection of the forensic evidence. We collect forensic evidence using a specific An Garda Síochána forensic evidence kit, where all the samples and everything are provided in this. Samples that we take are usually swabs, which are sterile cotton buds that we would use to take all the samples from the different areas of the body, which will be guided by the history that was taken earlier and documented in the patient's chart. We take hair samples, nail samples, and then swabs from every part of the body where there may have been contact by the assailant.
Now after 1 month, the patients come back to the hospital for a follow-up consultation. If we head into this room here, we're going to meet clinical midwife specialist Deirdre Richardson. Deirdre, tell me what happens.
So after the patient's initial visit, they attend here a month after the alleged assault, and the reason for that is we carry out a sexual health screen, which is in case they have contracted any infections during the alleged assault.
Okay, so there's a number of drugs on the table here. What do the patients take?
Everybody would get azithromycin, and this is an antibiotic, and this is preventative for chlamydia and gonorrhea. This would be the morning after pill. All females are offered this if they attend the sexual assault treatment unit within 72 hours of an assault. And everybody, male and female, are offered Energex B, which is a hepatitis B vaccine. There is certain risk factors, and if somebody has a risk factor towards HIV, we would offer them Pepsi, which is a prophylactic against HIV.
And although this is an extremely difficult time for patients, Dr. Ogan and her team are dedicated to giving the best care possible.
It's very important that whatever the patient needs, that we strive to provide that care. We can't help what happened to the patient, but what we can change is the response and the care that the patient gets afterwards. Because what we don't want is somebody who has a crime visited upon them, they come here to us in the sexual assault unit and they feel re-victimised in terms of receiving, you know, lower quality care, lower standard of care, or feeling that they're not supported in any way.
Re-victimised, that report there from Aisling Riordan, our reporter. It's really fascinating to see the inside workings of the sexual assault unit. Aideen, we saw you in the report there, and Susan, you work for the Rape Crisis Network. Is that an ongoing issue, that women do feel re-victimised when they begin to think about getting help, or indeed to think about going to the courts?
It possibly is. I suppose a lot of people don't know what's involved in reporting sexual violence until they're put into that situation. So when they come to a sexual assault treatment unit, we treat obviously everybody with huge dignity and respect, and try to consider all their needs. And that's why we work quite closely with the other agencies involved in giving a holistic care to these people.
Have you any idea, Aideen, can I ask you, of how many women actually, like what percentage of victims of sexual assault are you seeing, do you think?
It's very hard to determine. From international studies, it would say just maybe about 10%.
10%, really.
Yeah,
so
possibly,
about 90% of victims go
unreported, and where people don't come for any sort of help and intervention.
Do you know why? Can you, even from the women and men, because some men do come too,
indeed,
who do come to you, can you figure out it's guilt? Is it blaming yourself?
Possibly that people feel they won't be believed. And they don't know what services are out there and what the benefits of those services are to help them move on from this trauma in their lives.
So that thinking they won't be believed. I mean, Susan, the sad thing is they're kind of right, aren't they? A lot of women are not believed.
There's a whole variety of stereotypes that we carry about what a real rape is, who a real perpetrator is, and we use those beliefs in a way that allows people to think and that they won't be believed, and maybe to not believe themselves. Oh, I knew the perpetrator. Oh, I had a drink. Oh, you know, all of those kinds of things. People don't get those ideas out of thin air. They hear them every day.
Yeah, and I mean the statistics would support it as well. I mean the tiny number of sexual assaults that go to the courts, and then the tiny number of those that end up with convictions.
Well, and research would indicate that part of the reason that people don't report is because they're afraid they won't be believed. They're blaming themselves. They don't want to go through the process. They don't trust the process. They don't know enough about the process, or they know one person who had a bad experience 20 years ago, and that's what's playing on their mind.
Or they look at the coverage of sexual assault cases in the courts as well. Exactly. I mean, Aideen, when people do come into you, how do they end up with you? Do they know about you beforehand, or is it the guards who bring them? Or
the vast majority of our cases come through on Garda Síochána. Other people are referred maybe from their GP, or maybe attend an emergency department with other physical injuries and then are referred. Some people contact us directly themselves if they know about the unit.
That would be smaller, would it?
Yeah, a much smaller number, yeah.
So do you think that's a problem out there? That, I mean, I suppose a lot of people would know about the Rape Crisis Network, but they don't know about the medical help that's available for them.
Yeah, that there isn't an awareness of the units around the country.
that we need to talk to them a bit more. What are the new guidelines? What difference are they going to make?
So this is a copy of the 3rd edition of the national guidelines and referral of for forensic clinical examination. This, as I say, is the 3rd edition. So there's been a review of the previous 2 editions. The newest section in it is the option 3, where people can come to a sexual assault forensic unit and have forensic evidence collected without the presence of An Garda Síochána. Up till now, to collect forensic evidence following a rape or sexual assault, we always had to have a member of An Garda Síochána present
in the room?
In the unit to maintain chain of evidence, so that the evidence would then be admissible in court if the case does proceed to court. So option 3 then offers the person the facility to have the collection of that evidence and stored securely in the SATU before they decide to report it to An Garda Síochána. Because forensic evidence is time sensitive, the sooner we collect it, the more evidence we can potentially collect. So ideally we do that within 72 hours. Our cut-off time is actually 7 days. So,
but I suppose the new thing is that the victim or alleged victim can store that evidence to give him or her a chance to decide what they want to do.
Yeah, it gives them more time to decide whether they're going to report that to An Garda Síochána.
And that's vital. I mean, you can only imagine, just even watching that report, the trauma that those rooms would bear witness to, that many victims would need a bit of time before they take that step.
And in the units, there's a rape crisis person there to talk through options with somebody, but sometimes people are just not in a position to make a decision at that point. And this is a way of preserving somebody's options till they do get to a place where they can make a decision.
Can I ask you, Aisling, we hear a lot about alcohol. How much is alcohol still involved in sexual assaults that you're dealing with?
Yes, alcohol is a significant factor in a lot of the cases that present to us. In our national report, we found that about 70% of cases of patients have consumed alcohol in the previous 12 hours, whether that be a small amount or a large amount. And while alcohol doesn't make a person guilty or unbelievable in what they're telling their story, it does, I suppose, make them more vulnerable at the time, and can give them doubts themselves about being believed when they do go looking for help or to report that crime.
Absolutely, and also excuses the perpetrator at times.
Yeah.
I mean, you'd see that, Susan, a lot, would you?
Oh, sure. I mean, that's the great, lovely story in this country. Sure, it wasn't really me, I was drunk.
And it's still working?
Less and less.
That's interesting. So there is some kind of change in the judicial system around it. And would you say, I mean, coming from a rape crisis network where women can present 30 years later, 20 years later, are you seeing more and more people, can you see changes? Is it getting better for victims of assault out there, sexual assault?
Depends on what you mean by better. It's still incredibly difficult to report, even with all of the supports that are available, for instance, from Rape Crisis Centre, from a SATU, all of those kinds of things. It's still really difficult for people to report. It's still really difficult for people to identify that that's what's happened to them. There are huge variation in the kinds of difficulties. If you're 65 and you're talking about sexual violence that happened 40 years ago, we didn't have the same kind of language. We didn't talk about it in the same kind of way. Whereas if you're a teenager, you're operating under different kinds, in a different society and with a different set of beliefs. So it's still incredibly difficult. We still exist in a society that reinforces rape in a whole variety of ways, that sexualizes women, that sexualizes teenagers in a way that causes other long-term problems.
So we put some measures in place, like SATU, like the more rape, but there's an awful lot that we need to do yet to really tackle it properly. It's fascinating to hear about your work, and thank you both very much indeed for coming into us this morning.
Thank you.
And I think we have put some helplines up on the screen. There's a website there, rapecrisishelp.ie.